We're going to go ahead and keep moving. We've had a full day so far, but we've got a very important panel to wrap up the regular portion of our conference this year. We have 3 Montana citizen legislators, individuals who have been willing to devote themselves to public service, take time out of their lives, and work on behalf of the citizens of Montana, not only for the 90 days every 2 years, but in the interim on interim committees and as they are called on by their constituencies to perform miracles and do all sorts of other things. So we thank them for their service. We have also a former legislator, state representative, and senator with us. She will serve as the moderator and will also then introduce each of our speakers. She and I have occasionally been at loggerheads on various issues involving health care in the state of Montana, and I'm sure that comes as a great surprise to a lot of folks in this room. But I am delighted to be able to introduce the Regional Director for the Office of Intergovernmental and External Affairs for the U.S. Department of Public Health and Human Services, Kim Gillan. Thank you for being with us.
Well, good afternoon, and thank you very much for having the opportunity to not only come back home, but to participate in this very important forum. Before I get started, I just want to say one thing, is that the Office of Intergovernmental and External Affairs, there are 8 regions for HHS, and there are 10 regions and there are 10 regional directors. And we work for the secretary. And the reason I'm saying that is that people often say to me, well, why don't you change things in CMS? So I would like to say that I don't work for CMS. On some days, I wish CMS worked for me, but then if I were to think that CMS worked for me, then you'd be thinking I was sampling too much of Colorado's most notorious product. So anyway, with that disclaimer, I want to go on because it really is an important distinction, and being the eyes and ears of the Secretary in my 6 states, it's really important for me to come here today and have conversations and find out about how a lot of the federal level policies are matching up or at odds or complementing what's happening at the state level. So I'm excited to be part of this panel, and I was telling my fellow panelists is that this panel is where the rubber meets the road, and we're going to talk about how we can really move forward and what we're doing to go forward with health care reform. We've all heard a lot about the Affordable Care Act. And people like to say that there are 3 main pillars of the Affordable Care Act. One was accessibility and affordability, another was expanding coverage, and the third was system reform. But what I've learned over the last couple of years that maybe there are 2 other very important things to consider, and that is the consumer's role and the importance of educating consumers now that they have health insurance is that they are part of the puzzle, that they have to know how to use their health insurance and also know how to use the health care system. Because we think that that's really critical for any type of health care reform. And then the 5th, which I won't go into in detail, is that we all know from this morning when we heard about rise in health care cost. The 2 main drivers of those increases, up to I think 5.3%, in 2013 it was 2.9%, it is the increase in the number of people who have coverage, not just government coverage, but also private health insurance. So they're spending money not only on the health insurance coverage, but they're spending money when they're getting perhaps some long overdue care. The other is the issue of prescription drugs. And as you probably know, that's like 12.2% increase in the last year. And when you have people who have health care coverage and they can access the drug regime for hepatitis C, those are expensive costs. So I'm not trying to refute what the gentleman said today, but there are really a lot of facets that are involved in health care reform. And we all know, at least I know from my time in the Montana legislature, that there is no silver bullet when it comes to a very complex situation. So we know that in terms of access and affordability and coverage, you heard the information earlier today. Already 10,500 folks have signed up for Medicaid, which is great news. And then for the marketplace, there to date are a little over 11,000 folks who are out there signing up. I would be remiss if I didn't give a little plug. There's the Montanans, the boots on the ground that are helping people understand the healthcare insurance system are doing a fabulous job, and there is a great website called covermontana.org. And so in most of my states, we don't talk about Obamacare. We talk about, Get Covered South Dakota, Get Covered North Dakota, Enroll Wyoming, because that's so far more important to folks on the ground here that they're not they don't want to necessarily be involved with the federal government, but they want to be involved with some type of local or state health insurance. Now, probably the most controversial aspect of system reform that Health and Human Services is doing is the change in the way that they are making payments. And I'm sure that most of the folks are aware that some goals have been articulated for Medicaid or Medicare fee for service. There's a goal by 2018 that they're going to be tied to quality or value. It's something like 50% of the payments. They're also looking at additional incentives or, unfortunately, some punitive things so that by 2018, 90% of the Medicare fee-for-service payments will be tied to some type of quality of value. So that's the goals that the Secretary has set out. What I think seems to be more important, at least in my region, is the whole issue, and I think Jessica Rose talked about it today, is these innovative experiments that are occurring in state levels to try to look at how to have greater value for the dollars that we're spending, to begin to level off that or continue to have a more modest increase in healthcare costs, but also ensure that consumers are getting value. So the challenge we have is that, and I could hand you out maps and stuff like that, CMS is doing something what's known as the Healthcare Payment, Learning, and Action Network. And I would suggest, well, the gentleman this morning said that there were no tangible results that indicated it was having an impact on value. These things have just begun, and I don't think that there's enough information to really make that judgment call. The most important thing, however, is that at trying to be a partner through grant programs much like that Montana is involved, they're trying to look at what works in those localities or states in terms of the innovative delivery systems. We know in our state that there are ACOs that are already cropping up, and they address the issue of working not only with providers in terms of delivering the care, but bundling it or linking that to the consumer so that you really can't ever think that you're going to have an increase in the outcome and it'll facilitate some type of decrease in spending if you don't connect the provider more intensely with the consumer. There were a couple of examples today about people who are high cost. I'm sure in your ER rooms you call them frequent flyers, but that's why I said another pillar of healthcare reform is getting consumers involved in that whole picture. So it sounds good in theory, but we all know that a lot of it has to do with the actual practice. And that's why today I don't have a lot of examples, but we are working with every single state in our region. Particularly it's important because we have a lot of dispersed consumers. We have rural and frontier states, and so the viability of a concept like an accountable care organization or the reality of changing payments and linking them to value when there are a lot of unknowns are particularly important in our rural areas. And I think that that's almost demonstrated by the way that Medicaid expansion has rolled out in this region. And as we know, Montana has its own plan. Utah didn't pass it, but they had a plan that was very different from Montana, and a lot of that was tied to the importance of not just getting more people covered, but the next part of that, which is making sure that there is some type of systemic reform, because you can't expect people to get reductions in cost for services when there isn't some change in the delivery system. So I want to say that our office is a resource. There's a CMS Innovation Center. Unfortunately, a lot of the innovation projects are occurring in urban areas, but we've been pushing through community health centers and other organizations to promote these kind of demonstrations that are more rural in nature. You know, it's going to take a while. The system was not, I don't want to say the system was broken, because we in Montana, I think we have great providers, we have great hospitals, we have people that are inclined to work together. But the amount of money that was being spent for, unfortunately, the quality of care on a national level was beyond what could be sustained over time. So the federal government is using the two programs that it has the most control over, Medicare and Medicaid, to help actuate that change. It's not going to be done by those alone. As you know, there are individual providers and individual hospitals that are also part of that. So I want to say that delivery system reform, in my opinion, is really a work in progress, but it is moving forward. And the input that I've gotten today, the input that will come from the state of Montana, hopefully will help make a big difference in some of those regulatory. We've had a couple of victories already in the regulatory atmosphere, but I think it's really important, the work that you're doing here, and not just because, you know, there's going to be a change in the payment, but hopefully as these things become refined, that the experiences that are happening in this state will have an opportunity to do that. And I just don't want to miss the opportunity to know that everything here, the burden doesn't have to be on providers alone. Consumers play a critical role in making sure that the system reforms go forward, because use of the ER room, as we know, is the highest cost option, and we can't let that continue. So I'm going to let the rest of these folks share about things that are going on in the great state of Montana, and then we'll have an opportunity for folks to answer some questions and hopefully get into some more details where necessary. So the first speaker we're going to have today is, to my left, Representative Ron Ehli, and he's going to give us a presentation on some of the work that he did in the legislature.
Thank you, Kim. Appreciate that. And little bit about myself is, as Kim said, my name is Ron Ehli. I come from Hamilton, and I'm a third-term legislator. And in the last two sessions, I served on the Appropriations Subcommittee for Health and Human Services. In addition to that, I was on the interim for this current interim and the previous interim on Children and Family Health and Human Services. So we deal with a lot of different issues when it comes to health and human services. And before I get too deep, and I really want to thank the Chamber, Glenn Opal, and all the people that took the time to put this together. And most importantly, I want to thank them for this opportunity that I get to speak about mental health, because that's my topic today. And as all the topics that you heard about today, I know you heard from Senator Ed Buttry and the Medicaid expansion and the good work that's being done there. But at some point in time in the state of Montana, in the very near future, outside of this room, when you talk about HealthCare, that's what the world thinks you're talking about. But it's so much bigger than that, and I don't think the general public gets it. So I'm excited to be here today. I think it's a great day, and it's a great day for mental health, because this is what we need to do. This is the awareness that has to start in this program, and start talking about the things that are very, very detrimental to the state of Montana, our populations, our budgets, et cetera. So coming from the appropriation side, I sometimes get caught up in money. I don't mean to do that, but I'll get into that a little bit later, why it's important to chat about that. What I want to talk about a little bit today when I get into mental health is I want to talk about some of the past, the current, and maybe the future issues that we're going to have to address as far as mental health. And when I say past, I'm just talking about the last legislative session, and then we'll work forward from there. So in the last legislative session, I think it was a great session. I think we had a great opportunity to bring mental health and mental illness to a higher degree, to a level of awareness. And there's a few bills that came out of that session. And actually, I'll take it a little bit further back because they came out of a bipartisan interim committee in 2013. So bipartisan meaning we were evenly split with Republicans and Democrats. And why that's so important is because we don't always see eye to eye. I know that comes as a big surprise to a lot of people. But to be able to pull these bills out and bring them into the legislature and be able to push them through at the level that we did, it's kind of amazing that we got so much done. At least it seems that way to me. But House Bill 47 is just a bill that every one of these bills I'm going to talk about just briefly. It's about crisis intervention, jail diversion. From my perspective, it's about preventive care and working towards that end of the spectrum, that end of the mental health spectrum that we're trying to get to. House Bill 47 was a youth crisis diversion bill. It's a pilot project that's being created as we speak. Again, mental health and the youth in this state are struggling to get the services that they need, and we need to put together these projects to be able to have these children into short-term residential care, trying to move them into the care that we need to do as far as the state. And most importantly, when you get into these topics of mental health, we're going to have to start talking about outcomes. How are we going to be successful? How are we going to be successful to get the outcomes that we need for those, whether it's youth or adult, and it comes to mental health? That's some of the discussion is going to see. So House Bill 47 carried by, let's see, I forgot. Pease Lopez, Representative Pease Lopez. Great bill working on youth diversion and keeping them out of higher levels of mental health care. House Bill 33, 34, and 35 were three bills that came out and went through the legislature with really, really bipartisan support. Very successful bills talking about, again, crisis intervention, jail diversions, talking about secure psychiatric treatment beds, talking about voluntary inpatient mental health treatment. And every one of these bills, and I know that they passed the House, these three bills passed the House 100-0. So that gives you some idea of the awareness that's becoming on mental illness, and it gives you some idea what that bipartisan interim committee did to bring mental health to another level. If we don't start talking about mental health at the highest levels, if we don't start pushing the issue and the awareness of mental health, we are going to be inundated. We're going to be buried in this state, and I'm going to talk about that a little bit when we talk about the future. So the reason that it's impressive that House Bill 33, 34, and 35, they're really extension of previous bills. For those of you that follow the legislature, there were some 130 bills back in the 2009 session, and these are an extension of that. So we found the desire and the need to continue to build on mental health, and the fact that the legislature were so progressive and anxious to get these bills out of the legislature is just proof that we are moving in the right direction. But the greatest thing about these bills is they were all general fund dollars. And again, here's that appropriation thing that I talked about, general fund dollars, and you start talking about general fund dollars without the help of federal dollars in the state of Montana. Everybody's looking for a little bit of help from the feds, but at some point in time, I feel the responsibility falls on us as Montanans to take care of our own. And the fact that we were able to pass these bills with so much support tells me right up front that we do have the support. We do have the support from the legislature, and I think from the people of Montana. So when you start talking about those particular bills, you start talking about spending general fund dollars without the aid in this particular instance of Fed dollars, you're talking about Montanans investing in Montanans. I think we're starting to get it. Now, I will tell you right up front that I'm a Republican. Republicans don't generally get health care all the time, but I think it's proving. And Senator Cafferro probably says maybe you get it, you just don't understand it. Fair enough. Until we realize that's the case, until we do have the Republicans and the Democrats and us as a legislature pulling forward with this, until we admit that we don't understand it, we're never going to get anything done. So I think there's your awareness. There's the fact that the level of understanding is starting to grow, and I think that you're going to see good things come in the future. So some of the things that come with understanding is starting to understand how are we going to afford mental health, how are we going to afford dementia. With the graying of Montana, you're going to see more of that as Senator Cafferro speaks the next time in the next set of this panel. But we need to start talking about outcomes. We need to prove that we are actually going to get some results from the dollars that are being spent in the state of Montana. Which brings me to what we're doing currently in the interim committee. In the interim committee, we've got three directives that come from the legislature to do. I won't give you the numbers, but we're looking at developing pilot programs for the children's mental health and the outcomes that we talked about. We're looking at mental health investments in the state of Montana. In other words, we passed the bills, and now, as a legislature, we're going to start measuring, we're going to start looking at these bills and the investments that we made, and are they really creating a difference? Are they making a difference? Are we really going to get something out of the dollars that we're investing in the state of Montana? If I can't answer that for you as a legislator, I'm not doing my job. So in today's world, with what's coming down the pike, and you all have heard it all along, there's a crisis coming. We better start taking a look at how we're going to afford everything that's going to be on our plate. And then lastly, we're working on, again, talking about measuring outcomes. The objectives that we're trying to set up in this pilot program to measure these outcomes in the state of Montana, we're going to be monitoring DPHHS, which is the department, and the objectives are to get more community-based services, is what those bills, House Bill 33, 34, and 35 was all about, thinking about preventive care, thinking about community-based services, dealing with the issues at the best level you possibly can, which is at the community level. And so I think there's a move that direction. The way that those bills pass the legislature tells me that the move is towards community-based care versus institutional. We're going to be taking a look at different treatment options. Again, we're going to try to improve outcomes and most importantly, increase the communications that go on between providers, the department, and maybe some of the state facilities. So last, as I wrap this thing up, I want to talk about the future. And so what is the future of mental health in the state of Montana? I said it's an exciting day, and it really, really is. I know that we're not even close to where we need to be with mental health and some of these other issues, but we've started the discussion. We've got a legislature that's on board with the improvements that got to come. We got to start measuring outcomes. We got to move towards a more preventative care system versus the acute care at the state institutions, which means, in my opinion, we're going to start moving more towards community-based versus institutional care. It's the cost, it's the effectiveness, it's where the rubber meets the road, and that's where the things are going to get done. And last thing, from my perspective, when you move towards community, you're moving more towards private industry versus state-run institutions, and I'm just here to tell you, in my humble opinion, that there's a whole lot more effective things done in private industry than state-run institutions. So, closing it up, finishing it up, it's a great day because of the awareness. I think that from a mental health standpoint, and what Senator Cafferro is going to talk about, we're headed for a crisis if we don't deal with this now. And I think the legislature is getting a handle on it, trying to get on top of it, and get to the point where we can not be buried by this down the road. There's going to be discussion. Here's my last appropriation statement. There's going to be a bigger discussion about health care in the state of Montana, and here's the reason why. Currently, DPHHS is 43% of the state budget. 43% of every dollar spent in the state of Montana goes to health and human services. At what point in time do we have a bigger discussion about how we're going to afford those costs in the future and bring effective care? So is that 45%? Is that 50%? I will tell you this. I think health care in the state of Montana, with the graying of the Montanas, with the mental health issues, with the wars, with the people we're bringing home from those wars, you're going to see this become a big, big issue. And I think that I'm proud of the fact that I get to be a part of bringing this message to Montana now before it's too late. Thank you very much for your time.
And thank you very much, Representative Ehli. I think I just quickly would point out that the other thing, as you all know, one of the major health reforms is the integration of behavioral health into the primary care, and there are lots of pilots going on. The challenge is that how you get two separate reimbursement systems for two areas that should work together. So Montana's efforts are a great step forward as we move towards more community-based and that integration where primary care and the behavioral health specialists can work together and hopefully better outcomes and save some dollars. So next we're going to have Senator Cafferro, and she's going to address some of the issues that she's been tackling in the legislature and moving forward.
Thank you, Kim. So I sit on the Children, Families, Health, and Human Services Interim Committee. I'm the vice chair, and Representative Ehli is the chair. And we both have spent a couple of sessions on the subcommittee of Health and Human Services. And in addition to that, I sit on the Public Health and Human Services Policy Committee in the Senate. So everything is Health and Human Services for me. And I want to tell you that I'm grateful to be here, and really important is I'm grateful to be part of the process of being able to make positive change for Montanans who I care so much about. My question was to give you an update on the guardianship study, and I'll start with saying I have a question for all of you. And my question is, how many of you in the audience have had a friend, a family member, or a loved one who has been impacted by dementia or Alzheimer's? Please raise your hand. So that is why our committee voted unanimously to study Alzheimer's and dementia along with guardianship. We recognize the impact to Montana, the impact to families, to our loved ones, and we also recognize that there's a huge momentum in Montana at this time. So what perfect timing to piggyback off of other people's efforts. So I'll talk about those two things, the impact and the efforts going on already. So as far as momentum goes, the 2015 legislature invested money in research called the Legislative Research Initiative. And some of that money went to funding a study in Alzheimer's at the Montana State University. The research is being conducted by Dr. Matt Byerly at the Center for Mental Health Research and Recovery at MSU. The research will bring open-label studying for what's called transcranial magnetic stimulation for Alzheimer's disease. They're working in coalition with the Butte Community Mental Health Center. And the Butte Community Mental Health Center, of course, is located in Butte. The participants are going to be their patients who have Alzheimer's. So that's really on-the-ground work. This was spearheaded by NAMI Montana. They're key leaders in the development of this partnership. What they're studying is electrical and blood flow patterns in the brain, and according to Dr. Byerly, there's evidence that TMS works for some Alzheimer's patients. They already know that. What they don't know is why it doesn't work for all Alzheimer's patients. So they'll be studying to see who it is effective with and why. It's a concrete example of a multiplier effect of the legislative investment because of Montana's partnerships working on the effort of Alzheimer's patients, their families, the private sector, the legislature, and local community providers, and the university system. I'd like to add to that the private sector partner is a company in Bozeman called Neuralinks, and Neuralinks is designing the machine that they're going to use to do the stimulation. So again, it's a concrete example of all of these different community members coming together to partner to tackle one of Montana's biggest healthcare challenges, dementia and Alzheimer's. The second example of good momentum going forward right now is the Alzheimer's State Plan Committee. This committee, their objective is to draft a state plan for Alzheimer's and dementia. It's led by people in the field. It started out with a small group of people, and now people are numerous people from around the state are gravitating towards it. It's a good cross-section of people in this issue, including caregivers. Dr. Kuhn, who works for the Billings Clinic, and she's the medical director at St. John's Lutheran Home, which has a whole spectrum of care for Alzheimer's. And again, it started out as a small group, and now it's becoming quite a grassroots organic effort. The last thing I'll say is that they believe that quality of life can be improved and made better, and they have come up with, at least their policy group has come up with a list of policies that they shared with us at our last meeting, and I'm talking about our last committee meeting. Our committee met in Billings a couple of weeks ago, and I wish I could explain to you. I don't have the tools to communicate how wonderful and meaningful the information was that we received and how courageous the people were who came and testified. We had doctors, nurses, caregivers, people that are on boards that work directly with people who have Alzheimer's and dementia, and the caregivers really clearly outlined some of the tough issues that we have to face, and we need to find Montana-made solutions too. And that is that people are going in complete and total debt to take care of their loved ones. They're losing their homes, they're cutting down on their hours at work, or completely leaving their jobs to be their caregivers. And dementia is experienced, the majority of dementia patients are women. So this is an everybody issue. One caregiver explained that she had to watch her mom, who had dementia, and her dad, who had dementia, on their anniversary, and dad said happy anniversary and mom didn't know who he was. It's a very serious, financially impactful problem that we have. However, some of the solutions are really cost effective, and they're not asking for a lot. What they're asking for and what their priority is, and I hope the committee's priority will be, is to develop a system that helps people stay in the homes. Number one, the home is number one. It's in the best interest of someone who has dementia to be in the home where they're familiar, and it's in the best interest of the state budget to provide the supports to the caregivers so they can care for the people who they love. And the people who are suffering from dementia and Alzheimer's can be cared for by the people that they love. It makes the most sense, and it's the cheapest. Some of the things they asked for were respite care. They need a break. That makes sense. Another thing is somewhat of a private sector solution. They need their employers to support them when they need time off, and if they need time off, to take care of their loved one. And we're going to have to work together. Sorry, I just thought I'd do my own timer, but do you know how to shut it off?
Apparently we throw that. Look at it.
We got it. Okay. Okay, now what was I saying?
Said you did your own timer.
About guardianship. Oh, good thing I don't have any keys in front of me. Anyway, so the meeting in Billings was really helpful. We heard a lot of good information across the board, and that's where the committee is at today as far as an update. We're still gathering information. We don't have an agenda. We're out hearing from people and trying to identify solutions, and like I said, piggybacking off of already identified solutions. And the most important thing is that we support people to receive the care that will be the most helpful for them, for their well-being, their loved ones' well-being as well, and that's in the home. And then second are the small-based memory care units. And in order to do that, we can't be in competition with institutional care. I happened to visit the Montana State Hospital, and it is filling up with people, and should not be, who have Alzheimer's and dementia. We have to come up with a different solution, and everyone on this committee is committed to doing that. And so again, thank you for having me here today, and I'm really honored to be with my committee members and with, I keep wanting to call her Senator Gillan. And Senator Diane Sands is in the audience. She's also a committee member and has a lot to add to the subject as well. Thank you.
Thank you very Thank you very much, Senator Cafferro. As always, working on the cutting-edge issues. Next, I want to introduce someone I just met this morning. I'm not gonna even call him by his last name because everyone knows I'm terrible at names. But I'm going to call him Dr. Al. He's a state representative, and he has a PowerPoint presentation for us. So take it away.
Well, thank you, Kim. You know, it's kind of hard to have a doctor, not a PowerPoint presentation. I'm Albert Olszewski. For those that you know me, I think the best way to say it is I'm a freshman legislator. Therefore, I'm really just a person of no consequence, right? So, speaking to my senior legislators, really, we're getting towards the end of the day, so I want you to lean in for just a few moments, because I'm about to tell you something that I know that all of you are going to share with somebody by the end of the weekend. And so just the other day, I was in my office, and this little 4-year-old girl said to me, she said, Dr. Olszewski, do you know why you don't or bears don't wear stockings? And it stopped me when I was in the middle of my work, and I said, because they don't have shoes? She said, no, silly. It's because they have bare feet. All right. So there needs to be something that you're going to take home. Really, for the next 10 minutes, what I'm going to talk to you about is kind of take this whole day and also an area of interest in one of my interests in healthcare policy, and I'm going to drive it into a snapshot of looking at what healthcare redesign is from a governmental point of view and put it through the lens of a surgeon. It's all about the meaning of words, right? Population health management depends on who's speaking. We heard this morning from Mr. Kaufman that his definition that he would love to have is different healthcare systems for different people designed to meet their unique needs, and I think that's a great definition. From the federal level, population health management is it's a process to have a healthy, productive citizens that pay taxes. All right, or they don't use resources or minimize that use. And at the state level, I think what you heard, from Jessica Rhodes is, hey, this is a work in progress. So lean in on that. This is not over here in the state, and you can be a part of it. Oh boy, well there we go. All right. Historically, health management has been a personal issue. If you had a problem with your health, if you were sick or somebody in your family was sick, you would find a provider. Is that a shaman? Is that a doctor? A bone setter? What it might be. But you found a provider, initiated a relationship, and care was rendered. And really, it was the cost was borne on by the individual or the family, and it was based on your ability to pay. It could be money. It could be a chicken. It could be a dinner some other time. But over time, medicine became more successful. It became more scientific and became more expensive. And with that, it just continued to move on. And because it became more expensive, well, this new product came out, health insurance. Do you know that the first health insurance, when it was first started back in the 20s and 30s, it had nothing to do with paying for health care bills. It had to do to replace your salary while you were hurt until you could get back to work. That was the first form of health insurance that was ever around in the early 20s. But then it evolved into a mathematical, actuarial-based risk product that helped you when you had disasters or catastrophes. But even with that there, not everybody could have it. And as time went on, I see the giants that are providers in this room, and I appreciate what they did and what they taught me. But, hospitals took care of everybody. And, physicians had privileges. And with those privileges, it wasn't a right to practice, it was a privilege. And with that, there was an unwritten rule that you're going to provide a certain amount of charity care to work in this hospital. And it was a pretty good system. But it became more expensive, became more scientific, higher technology, better success, but more expensive. And that kept going and going and going until really, as we know over the last 20 years, it's really become very expensive. All right. Well, then the Patient Protection and Affordable Care Act happened. All right, 2010. Now, ACA is so extensive that it affects almost everything that occurs in healthcare and beyond. Right? But one thing is for sure, the government's role in healthcare has shifted from one of regulation to that of payment and management. Okay? It is clear to those that are working in the front lines of healthcare that the patient is no longer the customer. All right? The payer is. The patient is now relegated to the status of the payer's client. And that is seen every day in the front lines when we have to spend more time dealing with the payer and negotiating on behalf of our client or their client and our patient. But why? Why is that? Well, let me put it down to you in 3 simple statements. We, Who's we? Well, it's the leader of they. Well, that's really the government. We own it, all right? We can't afford it, and therefore we have to change it. So the government now is the major payer for the majority of Americans. 1 out of 2 Americans receive health care on the public health dollar this year. And in 8 years, it's going to be 3 out of 5. Well, the government cannot afford the current health care system, even though they have received significant discounts in fee-for-service through their leveraging providers. They still can't afford it. And therefore, they have to redesign it. So remember the tragedy of the commons? If the ranchers don't get together with cattle and figure it out, the government will. And the government is ready to lead on this situation. So it's changing. And it's important to know that everybody's expectations are going to change. Payers, providers, and patients. All right? Here in Montana, what we're being told is that at the state level, it's a blank sheet. We can experiment. In fact, the federal government wants 50 different experimentations so we can figure out which is the best system. And it starts here. And you have a role, and you have the opportunity to play, to put something on that blank sheet. All right? But the government asks for something. They ask for a triple aim, which means that they want to control costs. They want to make sure that they pass the risk from the person who pays to the person who provides the care. And oh, by golly, we want that data. In fact, sometimes I feel as a provider, I'm getting paid not to take care of patients, but to provide the data on how I provided that care. Okay? The amount we're going to pay for healthcare management in this country is capped. And in fact, in 2016, when the Independent Payment Advisory Board is convened, they already know that they're over budget, and they're going to have to make some hard decisions for 2017 on how to keep our healthcare under budget. Everybody needs to be covered. Enough said. And you know what? We also know that we can improve more people's health through public health projects and social engineering. So what does that mean? Well, for me as a doctor, that means we pasteurize milk, we give vaccinations, and we do sanitation. We make sure everyone has clean water and they have some place to use their toiletries. But it also means, to a lot of other people, it means a roof over your head that doesn't leak, subsidized electricity. It means, no stairs. It means ramps. It means transportation to wherever. So those are the things that are going to be coming up on the horizon. So to get back to the state's definition of a population health management, well, it's to be defined. And I'm telling you right now, it's going to be defined in the next year. So you pay attention to what Jessica Rhodes doing, and you pay attention, and you need to be involved. All right? Because either you're at the table or you're on the table. And you better be helping with the lifting, because if you're not helping with the lifting, you're going to have, then you're not going to be able to have influence in the end product. And guess what? We're all going to live with the results. And that's it. Thank you.
And thank you very much. Very much appreciate it. And I think that the three panelists, some of the stuff I've said, should be food for thought. So we are now happy to entertain any questions. What? This is a man after my own heart. He said we should have planted a question, which we would do in legislative committees all the time. Whoops, I shouldn't have said that. So, used to. But now you don't need to, because people just text in questions on your smartphone. Another secret given away. All right, do we have any questions?
We have a question.
Well, good. Thank you for that great presentation. I'm Amy Gramalis, and I lobby for the Billings Clinic, and I want to thank the committee members for being with us today. They're doing great work on behalf of that interim committee for all of the various topics. And I guess I was just curious, given the last presentation, Representative Olszewski, how the population health part of it will fit financially in with the other two topics that we've talked about with dementia and mental health. I mean, is there a way that fits into population health management? And how do you see us looking at the cost containment? I think that Representative Ehli talked very much about community-based, and Senator Cafferro talked about the keeping folks in their own home, and those both being cost-effective methods. But I was wondering if that was part of your thought process in concluding the panel.
Well, thank you for the question, and it does. I mean, once again, healthcare redesign is not about taking care of people who are broken or hurt or are ill. It's about taking care of, well, it's all about all of that, but it's about more too. We're going to be working our way towards transitioning towards prevention. We're also going to be working with healthcare. What we're talking about is driving the cost from an institution where it's very expensive into the community where we're hoping that it's less expensive so that we can provide more global health care to more people, but with less money. Okay.
Thank you. I wanted to add to that as far as cost goes. In Montana, Medicaid funding for people with Alzheimer's and dementia in the next 10 years will increase. Montana Medicaid funding will increase in the next 10 years by 52% if we keep up doing what we're doing today. Second, approximately 12% of the 2015 Medicaid budget in Montana goes for Alzheimer and dementia.
I'm going to address that just a little bit too before we go on to another question, because it's really important. And I did allude to it. Thank you for that. And how are we going to afford to be able to take care of all the things that are coming up? And two of the issues that are big in our interim committee are mental health and dementia. And when those two get and hit their peak, well, who knows what that will be? It certainly is today. It is going to be a crisis. It's a crisis just looming to happen. So how do you judge? I'll just speak to mental health again, and I want to reiterate the fact that the move in the legislature and the move in the bills that were put forth is the move to go towards community-based care. And community-based care isn't necessarily home-based care when it comes to mental health, but it is taking care of those people in the community. Why do you want to move to community-based care versus institutional at a state level? It's really simple. I think all the statistics show that if you're at home and you can be closer to a home environment, it's where the rubber meets the road. It's where the people are more comfortable. If you can prevent a mental health crisis rather than move toward the acute side of the scale and end up at the Montana State Hospital, I don't have to tell you what the cost differential will be. So it's all about prevention as we move towards these costs. The cost of healthcare itself will never go down. That's a given. There's only so many dollars that are going to be produced. So now we find the efficiencies, and in those efficiencies are also the effectiveness, which was I was talked about also, which are the outcomes and proven outcomes in the mental health field. Thank you.
And I just wanted to jump in. To be candid, I think one of the criticisms that we've heard about the Affordable Care Act is that people said, oh, this is great that more people are going to have access to health care, but how are we going to continue to, or how are we going to address costs? I think that the first speaker this morning was very, very concerned about that. So given that situation, I think that there are elements, I know there are elements in the Affordable Care Act, and that's why the Secretary started the beginning of 2015 by setting out her goals. The real key is how do you move towards a fee-for-service system that was based on quantity and transition that to one that's based on quality. You don't do that overnight, and if you have to sort of juggle it all as more people are getting care, precision medicine, the recognition of huge drug costs, that what we're seeing now is the bundled payments and the value-based payments. I'm not trying to defend it. It's kind of a work in progress. But as we heard this morning, there has to be some type of movement towards controlling health care cost. And too many stories about the same person going from one hospital to the next and getting the same test done. And that's as part of, there are a lot of different pieces to the puzzle, electronic medical records. To be honest with you, I now, down in Denver, I've stuck with the University of Colorado, not because I think everything's perfect, but everything's in one spot. And so I don't have to worry about transferring information to other things as the consumer. So I just felt that we had to make a transition, and the quantity to quality is one vector that we're on right now.
Yes. Okay. I'm Jane Amdahl of Helena. I represent AARP, one of the copper sponsors for this conference. And I don't have a question so much as I just wanted to thank the legislators who have, all three of you have been, from what I hear here, working on lowering healthcare costs by keeping people in their homes, or if that's not possible, in community-based services. And that's something that AARP, it's one of our big priorities this year, and frankly always. And to the extent AARP can help in any way, whether by advocacy before the legislature or anything else, we'd certainly like to hear from you. So thank you very much for all you do.
Thank you.
That certainly wasn't a question, but I think that when we start talking about the issues that are coming from the state of Montana, your involvement in this, it's the people in this room are going to make this happen. As legislators, we listen a lot. In this committee, we've got a great committee members that were introduced earlier, but we can get nothing done without the support of the communities, and you're absolutely right. It's the people in the field that get it, the people that understand that it's communities and we got to move more towards that community-based care. So it wasn't a question, but I just wanted to give you the kudos for standing up and saying that, because it's right on track.
My name is Bernard Reese. I'm from Pomeroy Medical Center in Conrad. I guess I have two questions, one on the mental health end of it. How are you going to help small rural communities come up with the resources to handle the mental health patients? We don't have it. And on caregivers on Alzheimer patients and stuff, generally, the caregiver is the one who suffers almost as much as the patient, and then you have two patients on your hands. I'm not hearing it right, but you want to increase home health care, but you're putting that on the caregiver, the wife, or the husband, or the son, or the daughter. And I've been there, and they're the ones who suffer and health goes down. And then you have two patients. It's like, how are you going to address, I guess, those two issues?
I'll address the mental health issue first, and it's a really good question. So House Bill 33 is a grant program, and it's not a perfect program, but it was designed to go out and touch bases with communities that are struggling for help. Eastern Montana is in dire need, you're absolutely right, in dire need of health care, mental health facilities. And what House Bill 33 is designed to do is a grant program. It's to force communities to start the discussion. And I will tell you this, that not even at House Bill 33 and the dollars that are designed to go out there, it still is a three-way street. And House Bill 33 was designed to make and get the communities to understand that they have a fight in this battle. And so I'll just give you an example that happened in my hometown with the West House in Hamilton, and it's a three-legged stool. Not only did the state come out with the grant money, but the community has to match that money. In addition to that, the private sector stepped up. So that's where the discussion is going to go. Now, your particular county, as small as it is, and the population isn't there and the tax base isn't there, you still could ask the question. But I just think there's a solution, and I envision a multi-county getting together, because if the closest mental health facility is in Billings for everybody east of that, that's just not a very good model at all. But that's what it's all about. So I'm not here, and I can't tell you that here's a check and go get it done. But it does start the conversation, and it's an excellent question, because it's the solution that we've got to come up with. And I see Eastern Montana, which I'm originally from, by the way, is a multi-county potentially at some point in time.
Thank you for asking that question. I wouldn't want people to leave thinking that what I was translating from what we heard from the audience was that it's all up to the caregiver to do the work, and you're absolutely right, and speak from the experience that this is a family issue, and the caregivers suffer as much, if not more, as the patient, and then that creates a whole downward spiral because what we heard was their health is severely harmed by caregiving. And so what I was talking about, and I'm glad that you asked to be specific, is support for the caregiver and the person with dementia. So respite care, so that the caregiver can obviously get a break and go do the things they need to do. One husband talked about how wonderful it was to get a break and go fishing. So respite care was really important. Another one was, people coming into the home and helping with bathing and meal prep. Transportation was very important, especially as if the person becomes has mobility issues. They need that nurse's aide or whatever they're called now, CNA, to come help. So those types of supports in the home. Not because the caregiver should be the only provider and it's all up to them, but if that's the choice, then I believe that it is our responsibility as policymakers, A, to respond to what we heard, and B, to respond in a way that is most helpful to support the family. And then the last thing was, not the last, there's plenty of things here that we heard, but the last thing that stood out to me was the workplace support for the caregiver, so that they can continue to work if they want to, and or if they need to, it's more need, and that looks like paid leave, so that they can take time off and go home and care for their loved one. Because as you know, I'm sure what's happening now is the person has dementia, and that affects them and everything they've worked for their whole life. They lose it. And then the person who caregives has nothing, and their children have nothing. So it's a generational issue. And people shouldn't have to lose everything just to be cared for. So I was talking about supports that wrap around the caregiver rather than placing all of the burden on the caregiver. So thanks for the question.
And I just add that one of the things that's great about Medicaid expansion is that there are a lot of folks who are not working who are low income because of their behavioral health issues. And so the Medicaid expansion hopefully will provide earlier access for some of those folks. And so right now, counties in Montana bear the burden when there are costs that are not covered. And so that's a step forward for that Medicaid expansion will help folks, some of the folks with behavioral health issues earlier. The fact that behavioral health is an essential benefit under the HealthCare marketplace and kids can stay on their parents' plan. There is actual data they don't have with me, but kids who are now have developed addiction problems, however, now are actually getting outpatient help because they can still stay on their parents' health insurance program. So hopefully those things will begin to take the burden off of some of the counties who don't have the resources.
And Senator Sands, it looks like you've got our last question.
Senator Diane Sands from Missoula, and I also serve on all of these committees. The other part that we don't usually deal with in this forum, and I know I brought it up in past years, that is related to behavioral health, particularly mental health, addictions, and some of these other issues, is that we're all paying for it in another part of the state budget, which is known as corrections. Right now, that's our biggest mental health system in the state. It isn't you guys. It's our correction system. And until we deal with the interface between those two, and I'm glad to see that some of the expansion of coverage is going to perhaps allow us to be able to share some of that cost and integrate some of the programs and the work we're doing in this committee to try to get people care in a community setting, not in corrections, but in a mental health, in an appropriate mental health setting at the local area, to train more people to be able to provide that care, is to me critical in terms of being able to provide what the Constitution requires, which is in the least restrictive environment, you have a right to treatment and health care in a non-restrictive environment that provides for a quality of life. And I think that's where we are really going as a legislature in terms of trying to focus on community services. But let's just remember, this is not just about hospitals, it's about how we provide care for people who haven't traditionally been covered by health care, but who have serious mental health problems or addiction problems, and we usually deal with them in corrections. Thank you.
So, Senator Sands, I'm going to pretend that was a question, but I'm going to agree with you. Is that, as I going through this session and spending, I probably read more than I had since medical school, I have to admit. And one of the positive things that I found merit in for the Medicaid expansion was on that exactly. Is that when we looked at the studies coming out of Illinois, where people were those that were incarcerated had Medicaid while they were incarcerated. They transitioned with a care coordinator into the community and was able to maintain their Medicaid. The recidivism rate was dropped by 16%. So, and for the bang for the buck, that was probably the largest positive impact that I saw, weighing the pluses and the minuses of the program. So.
Well, I think that was an extremely good panel discussion to have on topics as they're continuing to evolve, things we have to look forward to, and we do appreciate the hard work that all of you have given us and are continuing to provide on behalf of the people of the state of Montana. In Helena, we would like to thank you as a panel for your work today. And as moderator, thank you. We have just a few quick things before we go into our last topic. Just so you know, there are cookies available if anybody needs just a quick little sugar jolt. But in the meantime, I do have 2 wrap-up things for us to do.
Does that mean we get to go now?
Good job, everyone. Thank you.
Thanks, you guys. That was a pleasure.
Yeah.
Good job.
You too.
Kim Gillan.
We may leave. The panel is dismissed.
Yay!
Signy die.
Signy die.
First, I just very quickly want to go over what your responses were. We will have these out on the website as well, but you did a really fantastic job. I know that Jessica, Amanda, and everybody who's going to be working on the SIMS model will appreciate your input. And I will go through this quickly for you. But what are the biggest challenges in your community when it comes to addressing health disparities and better integrating physical health with mental health and substance abuse treatment? The first, lack of knowledge, education, and training of best practices, a common understanding of what disparities are, a lack of integrated care, separation of entities, unlimited needs and limited resources. Early childhood health and wellness education is lacking, competing interests and priorities. Mental health payment system needs to be better aligned with community stakeholders, reducing the stigma associated with mental health and substance abuse, lack of after-hours and weekend behavioral health resources, recruitment and retention of educated and competent providers. We will have the full documents available for Jessica as well, but that's just a quick summary. What are the unique challenges Montana's rural frontier nature presents in addressing these needs? And I think this will come as no surprise. Level of needed providers is not always available. Integrating care, utilizing case management, lack of money to attract specialists. Possible answers are telemedicine, transportation. There is today a disconnect in information exchange, fear of confidentiality and judgment, payment models that are urban and not rural or frontier, and alcohol abuse is an inherent part of Montana culture. The last question was, what opportunities would improve data infrastructure for addressing these challenges? Provider baseline to see if initiatives are actually helping. Improve data communication between systems such as EMR, continuity of care, communication, avoid duplication of services. real-time data accessible to everyone, connecting physical health and mental health, prevention education, identification of high-risk patients for early intervention. Legislature needs data to fund initiatives, and lack of rural representation. So that is the summary of what you all did. We now have our final presentation, and then I will have some wrap-up comments, and those are just housekeeping types of things.
Well, I know there's a few questions around about the plans for the new medical school in Montana. And personally, I think a medical school in Montana is going to be a really good thing for Montana. And this approach won't take taxpayer dollars or any Montana money particularly to get started. So it's another positive for it. And it'll address some physician shortages that we have in the state now, and that are going to continue to get worse over the next 10 years. So I think it's a really cool development for the state of Montana. And I want to applaud Dan Burrell for wanting to do this for the state of Montana. And we had Dan here in town, so I asked Webb if perhaps we could add on to the conference a little bit. So Dan Burrell and Dr. Robert Hasty, who's a newly hired full-time dean for the medical school, will be able to say a few words to you about the plans, and then there will be an opportunity if you would like to ask questions. So with that, I'll introduce Dan Burrell and Dr. Robert Hasty.
Thank you for the opportunity to be here today and for the generous introduction. John has just given me a tour, I think, of every piece of square footage in the Benefice Health System, so I feel particularly privileged. Thank you, Amy, for taking us around. And to see Great Falls, this is an incredible city and an incredible opportunity for us to come here and address such a distinguished audience. I want to respect everybody's time and respect kind of the opportunity that we've had. Robert's obviously just been introduced to you, and he'll speak a little bit about the school and particularly about the graduate medical education programs that we're trying to create here in Montana. But let me give you a little bit of background around what we're proposing to do. My name's Dan Burrell. I live in New Mexico. We are currently building a significant medical facility in southern New Mexico at New Mexico State University. 150 student medical school, and really a health sciences campus. And what I want Robert just to do before I jump in to the backstory is give a little bit of your background, and then we can talk a little bit about what we're doing in New Mexico, what we're proposing to do here in Montana, and a little bit of what we're doing with John and the folks in Great Falls.
Great. So thanks, Dan. Again, my name is Robert Hasty. I've been appointed the founding dean and the chief academic officer for the proposed Montana College of Osteopathic Medicine affiliated with the Burrell Group. And I've been in medical education a long time. Essentially, all my professional life. I originally started off as a hospitalist, teaching hospitalist, and I've done a lot of things, including development of graduate medical education and residency programs, not only in Florida, but also in North Carolina. And previous to this appointment, I served as the Associate Dean for Postgraduate Affairs at Campbell University Jerry M. Wallace School of Osteopathic Medicine, the first osteopathic school in the state of North Carolina. And through this process, not only did we start a new osteopathic school in a state with great need like the state of Montana, but we also were able to start 20 residency programs at 7 organizations, a total of 383 positions. And so I had some opportunities at the time, and I got a call from the Burrell Group for the need in Montana. And of course, I looked at the great need in the state of Montana, and Montana looks a lot like the needs that we had in the rural parts of North Carolina when I first went there. I think as everyone knows in this room, we have 12 counties that have a single primary care physician. We have 9 counties that have a single physician. We have the 4th oldest workforce in the United States here in Montana. And the future of Montana, the workforce looks significantly bleak right now. And right now, without a new medical school here, it's only expected to get worse. So I'm really excited about this. The Burrell Group, prior to me coming on, had hired Trip Umbach. They're the same organization that the University of Washington did that hired and showed there was a need to increase WWAMI several years ago. They conducted a pre-feasibility study, which we have released right now. It's currently available up on our website. And the pre-feasibility says that we do need a medical school in the state of Montana of its own.
Yeah, and maybe just to step back, I think I want to kind of help educate the community a little bit on how this has all come into being, and then speak a little bit on why we have a potential interest in replicating the model in Montana. And as I think Robert's pointed out, this is something that is still being looked at. We are working through a feasibility process, beginning to come to some preliminary conclusions and to release that information to the public in real time so that the public can weigh in. But my interest started 3 years ago in New Mexico. I have 7 businesses in that state. We're dealing with enormous challenges in our healthcare system. We have 32 of 33 counties that are designated professional medical shortage areas. We have a tremendous challenge recruiting and retaining physicians. And our hospital systems, particularly our critical access systems, which are almost entirely in rural locations, as you have here in Montana, have a tremendous issues around attracting physicians, particularly in the primary care area. So I was brought into a dialogue around what do we do about this? And there were a number of leaders from the medical community, from the business community, political leadership, and we began a conversation with one of the 2 flagship universities, New Mexico State University, which is our land-grant institution, much in the way you have Montana State University here. And where we began was, let's look at a public sector solution to this. Let's get the legislature involved. Let's build our second, what was in the case of New Mexico, our second medical school. Let's size it appropriate to the region. In that particular case, we have about a 2.2 million person population area in what we call the borderland, southern New Mexico, West Texas, and southern Arizona. And what we quickly found was that the budgetary constraints within New Mexico, the political challenges, the partisan political challenges around trying to get something like that done would have been almost impossible. And so we looked at a second option, and that second option was to go with a philanthropic solution. And when you begin to assess the real costs of building, financing a medical school, and then operating a medical school, especially if it's going to service a region, you're looking at a cost initially of about $125 million, and you're looking at ongoing operating costs in the early years at around 15 to 20. And those are going to be losses that you incur as you begin to build enrollments and as you begin to build out ancillary services around the core medical curriculum. So we didn't have, at least in the context of New Mexico, what I would call an angel or a donor, a philanthropic entity that was willing to step up and say, you know what, I will take on the entirety of that commitment and make this gift to the state. And so the question is, what could you do about it? And we were, as a family, asked to make that gift. We were not in a position to do it. But what we were in a position to do was to invest in a first of its kind in the nation innovative public-private partnership, which is primarily capital that we brought together through nonprofit foundations, very prominent university foundations and local foundations and, community organizations that came together to fund a private tax-paying entity that partnered with New Mexico State University to create the first ever public-private partnership between a major U.S. institution of higher learning and an independent freestanding college of medicine. And so we were very proud of the fact that over a 24-month period, we're able to bring together the intellectual capital, the human capital and the financial capital and resources to structure this. And so we affiliated with the university, and it's been a tremendous success. I mean, one of the big challenges that you have here is the creation of graduate medical education programs and the residencies that are necessary to get your students, your graduate students, into the workforce. And as many of you know in this room, 70% of those students are going to stay in the regions in which they do, or the locations in which they do their residencies. We had to deal with a fundamental question, and that question was, even if we could build the medical school, even if we could overcome all of those challenges with a group of community-focused, civic-minded, kind of leaders, of which we were proud to be one of them. Our name is on the building, but I would love when I have a chance to sit with many of you privately and explain the other great institutions who are behind that and what their motivations are. But I can tell you they're motivated by social impact, and they're motivated by helping their region and their community much more than they are motivated by seeing significant return on their investment with respect to this particular school. But what they and I struggled with was whether we could create those residency programs in the region, because without that, you are still, from our perspective, doing a national good. Doctor shortages nationally are dramatic. And despite kind of the noise that you hear out there about placing medical students into residency, last year, osteopathic physicians were placed at 99.4%, and MDs were slightly underneath that at about 98%. But there really wasn't a crisis of matching residents to residencies and getting them into the workforce. The crisis was in building them, and particularly building them in these underserved communities. So when you look at a state like Montana, where you haven't had a medical school, the motivations to create teaching hospitals, the motivations for hospitals to invest in the kind of educational programs that are necessary to support a school, the incentives weren't really there, okay? And until we introduced those incentives into the regional economy of West Texas, southern New Mexico, and I say that economy, the medical economy, in southern Arizona, we didn't see really the incentives or the motivations either. In the last 2 years, we've created now 8 different programs approved by the AOA and 108 residency positions. We have over 114 clinical affiliations. We've started residencies at 4 Virgin hospitals, none of which could have done this on their own. And it's been a pretty extraordinary sort of set of circumstances in how we've been able to change the landscape, not only in terms of medical education, but in terms of GME and in corresponding and related programs at the hospital level. So how does that all result in us sitting here in Montana? I think we had a relationship with Montana State University because the president of Montana State University was our provost at New Mexico State University, of which she was fantastic, and we were very disappointed that she was sort of lured away from us. But a lot of the medical staff that is on my team now at New Mexico State had a 10-year relationship with the WADED, and as you can imagine, particularly my president of the Burrell College of Medicine, who was the president of Mountain View Medical Center in Las Cruces, which we kind of look at as our benefice here in Great Falls. And when he took the job, one of his first calls was to WADED and others to say, hey, I'm taking this job, and here's the model, and here's what we're trying to accomplish, and here's why I'm doing this. And she said, my goodness, we have a lot of these challenges in Montana. And so that sort of started a process, I think, of her taking the leadership to go out and start really digging into whether a program like this could make sense in complement, sort of in working with the existing WWAMI program, A, and B, whether this might be the right thing for Montana. And so I was brought in as a family, our family was brought in, I should say, much later. But when we saw that what we created, which again, took the better part of 3 years, was very replicatable in Montana. And as Robert has pointed out, 52 of 56 counties here designated health professional shortage areas. You have 9 counties without a physician, 12 counties without a primary care physician. You got critical access hospitals that are hemorrhaging, trying to get physicians into the workforce. You got second largest health system in the state, doesn't even have a residency program. You've got 49 out of 50 states doing better than you in creating residencies. But even with all those factors, you got I think, something that's much more scary than that, which is a third of your physician workforce is 60 or older, which means you're going to lose close to 1,000 physicians in the next 10 years. You have a program here called WWAMI, which is fantastic, and it's bringing 30 physicians into the state each year for medical education. It's keeping 18 of them. But if 18 times 10 is 180 and you've got 1,000 physician problem, that's not by itself a solution. You need to do more. And I've been very, the first two questions I asked to Waded when I got here was, well, why don't you have the state fund it? Well, we don't think there's a consensus around doing that, and we don't think there's resources around doing that. I said, well, why don't you expand WWAMI? That to me seems like a pretty obvious solution. If you can increase WWAMI by 50 to 100 students, you could meet the needs of not only the state, but you could actually help meet the needs of the region. And we don't see that after having done a lot of work is going to be viable with your legislature. So you're back to a conversation that we had in New Mexico, which is if you can't do it on your own through the state legislature and you can't do it through the WWAMI program entirely, shouldn't you consider the idea of a medical school? And that's where our model comes into play. So let me tell you kind of what we've done. We've started with a pre-feasibility study, which we again released to the public, and that sort of looks at the situation in the state at a 30,000-foot level. And I think all the relevant data that you would expect to see in a report like that about doctor shortages, about your hospital systems, about your delivery systems, about your long-term needs, about your demographic challenges, that's all in there. And what it doesn't address is this critical second issue around how do we build the residency programs. And I want to make kind of two comments on this, and then I want to be very respectful of everyone's time here, but I felt like you all deserve this level of detail and explanation, and certainly will be available to speak with anybody who'd like to speak with me about it. But let me just get to those kind of 2 points. We will do a final feasibility study that will be completed sometime in the spring. And what that's going to focus on is, can we create the regional GME to support a sustainable medical school? And what do I mean by that? Nobody's going to build a medical school here, not the state, not the universities, and not us, that can't sustain itself. And that's not a discussion around for-profit or not for-profit or whatever you want to call it. Any nonprofit that's sustainable, any for-profit that's sustainable, is sustainable because it designs itself structurally to be. We are not looking at building a medical school in Montana with 125 to 150 students a year, where all of those students will be trained as graduates in this state. They will be trained in a regional economy, and that economy from a medical perspective is one of the only regions in the country without a medical school, and that includes Idaho, that includes Wyoming, and that includes Montana, and it includes no osteopathic school in the Dakotas and no osteopathic school in Montana. So you have this hugely underserved region, all of the states dealing with substantially the same problems, and you don't have an osteopathic school, and in most cases you don't have an MD school. And that's incredibly unique for a region of this size for the United States. So that's sort of one point. But I think when we start talking about the introduction of that school and we talk about creating sustainability to that school, the third thing is, can you create the regional residencies to support it? I know what the answer is because we've already done a lot of the work, but we need to prove it to you. We believe we can create anywhere between 100 and 200 residencies right out of the gate, right in Montana. But I can tell you, when you start looking at the regional sort of paradigm and the regional hospitals that are already in discussions to partner with us, we can we believe, we could provide, I should say, access to every one of our students for a residency position here in the region. And that would have profound long-term implications for your doctor shortage situation, for your hospitals. And so that's what we're considering. And I think if that is something that we ultimately conclude is the right model for the region, then that's very exciting for us as a family, because we've created a legacy that is not just here in the region, not just in New Mexico, but national. And that's really what we're interested in. I think if you look at kind of the work that we've done with primary care and sort of how we've been part as a family of a national discussion around that, you understand a little bit more about our motivations. But But why don't we open it up to some questions? I think to the extent, Robert is prepared to, he'll be spending a lot of time here as our, as the proposed dean of the new school. He'll be here through December. He'll be here through January. To the extent things are moving in the right direction, he will be here full time starting in February. And really his role, other than GME creation, is to very actively engage in the community to kind of get rid of this notion that somehow there is a lack of transparency around this process, that there is an unwillingness to provide information. I would say those things are not true. I would suggest that all of you visit our website, read the study, look at the fact sheets we're putting together, look at the student incentive programs and the debt forgiveness programs that we reference in there, because one of the key things for Montana to get these students into the rural communities is going to be debt forgiveness, and we know that. So we got to hit hard on that, and we're working on it, kind of every day. And and then let's start having a conversation about if this can be the right thing for this community. So thank you, for your time, and please, we'd love to entertain any questions.
Hi, my name is John Griffin. I'm a family medicine doc and medical director of Blue Cross Blue Shield of Montana. And I'm asking this question from the perspective of being a former medical student. I did a few rotations here in Montana during medical school, and it wasn't always easy finding a preceptor to teach me, and you've alluded to the fact that there are shortages of physicians in Montana. So what is the strategy for finding physicians to train medical students in the state with increasing the number of students?
Yes. And first of all, I appreciate your comment, Dr. Griffin. And the model that we have is to make sure that every medical student has a place to train that's going to give excellent education to the medical student. We would not start this medical school unless we feel very confident that we'll have excellent in developing the quality physician for the future. And hearing about your story that you were having to try to find preceptors to train you, I mean, as a medical educator, I don't think that's something that the medical student should have to do. And what does it take to train the physician of the future? And I can tell you that the Burrell family is focused on quality, making sure that we develop the best medical school possible. And that's a team-based physician. That's a quality, caring, compassionate, expert physician that is trained in an environment that is supportive and nurturing to that medical student. And a lot of times in medical education, I mean, it's just not, presented on the silver platter. I mean, you have to really try to seek out the best teachers and the best faculty members out there. And so we'll be very exhaustive with our process as we go through the feasibility study and, see not only the resources here in Montana, but also for the entire region.
And I think it'd be worth you speaking with Dr. Hasty a little bit about, this isn't the right forum for it, but anybody who wants to kind of look at how we've dealt with this issue in New Mexico and how Dr. Hasty's dealt with this issue in the Carolinas, it's very instructive because the challenges were, look, they're always situationally different, but they were as close to identical as to what you're dealing with here in Montana as could be possible between different states, different populations, different geographic locations. So I think that's going to be very important, and I would suggest, for physicians in the room like yourself, to spend the time with Dr. Hasty to understand that. One of the motivations for me in bringing him on was this, the development of the support systems around the school, which are essential to fulfilling the mission of the school and the objectives of the school and the objectives of the region. This is quite literally what he did and has been recognized for nationally, and it's pretty extraordinary when you look into Mr. Hasty's background. And again, I would also reference you to our dean of the medical school in New Mexico, which obviously is still in its infancy, but if you look at what's been accomplished, Dr. Moderator, who is somebody we'll make available to this community, has done the same. So I wish we had more time to kind of give you more detail, but again, this is not the only venue in which we can have this discussion.
Mr. Burrow, Dr. Hastine, thank you for coming and spending time with us. As a legislator, one of the things that I've seen through the education, especially for allied health, is that we have a lot of schools that have the ability to academically train more nurses, more physician's assistants, more advanced practical nurses. Problem is the clinical rotations. So could you explain your philosophy on the level of rotations here that can assuage the anxieties that we're going to have from allied health, that you won't dilute this kind of scarce resource, or how are you going to add to it?
Yeah, absolutely. And I'm glad that you mentioned, the nurse practitioners, physician assistants, allied health. We think that training the physician of the future includes a team-based approach. That's what the public expects. That's what we expect for our medical students. In terms of capacity, one of the metrics that I looked at, and I did my research before I took this position, there's a lot of capacity in Montana. Even though that folks are, saying that there isn't capacity, there actually is. One of the metrics, the first metrics that we look at if a state has capacity, is the number of graduate medical education positions per capita. And as Mr. Burrell pointed out, it's, Montana's 49th out of 50 states in GME positions per capita. There's, we just had this amazing tour of Benefice, and what a great facility, and the number of deliveries. I mean, they're doing 135 deliveries per month, and it's just all these amazing opportunities for trainees to learn and deliver, have their OBGYN experiences, and this would not dilute the training of physician assistants and nurse practitioners. There's, if you look at the region, I mean, we have 3 states contiguous without a medical school of their own. So there's opportunities here for sure.
And let me just kind of comment specifically on that, because the next phase of the work that we're doing is specifically intended to address that issue. And I've cautioned people as we've moved around the state, because there's, we kind of want answers now. Give me an answer. And we're not ready to give you an answer on that because we're still finishing our study. If we had an answer, we'd be announcing the medical school. So I think what we're focused on right now is making sure that the answer to that question is affirmative. But as Robert has just pointed out, when you're last in something, it's rational to think that there's room for improvement. The question is, how much room for improvement is there? And that has to be it is really scientific and quantifiable when it comes to setting up clinical rotations and clinical and residencies, because ultimately it's going to come back to your hospital system partners. And that's where I would kind of put it back on us and let us prove to you that we can create those problems without diluting the existing population of rotations and residencies. And if the answer to that is we can, and we can significantly expand capacity, then we're going to kind of put it back on you, i.e. the community, and say, well, we think this is a good thing, and we want you to embrace it. So let us kind of, that's another 3 to 4 month process. And I wish I could share more with you today on that, because there's a lot of confidential discussions going on. I mean, John is somebody that I would talk to here at Benefice, but we're finishing our analysis with them on what we think the capacity is just at that one system. We're talking to about 8 systems actively, and I will be able to give you some very direct feedback on that shortly after the new year.
I think they answered. I think you just answered my questions. Billings has a residency program, and Kalispell is about to start a residency program. I wondered how that would be affected by what you're doing, but I think you just answered that you'll be looking at it.
Yeah, again, to save time for everybody, what I would just recommend is this will be put into a comprehensive study and a report. You'll be able to look at each system, how we've designed, what programs, and then what slots tie back to each system. So I think from my perspective, it's not that in the case of Kalispell, we can help them in the creation of new programming, but I think the smart thing at this stage is let us finish our work, let us come back, give you as a community an opportunity to review it, and then we can make some final decisions about this.
Thanks again very much for being willing to take time to answer questions from this group. It's very much appreciated. You alluded to building the establishment in New Mexico through a combination of public and private partnerships and an affiliate relationship with the university. Is that the same model that you anticipate here? And what does that affiliate relationship with the university look like? Is that shared curricula classes, buildings?
Great question. So, and I will just be very candid with you. I came to this with a bias because we never expected to do more than one school. So, to the extent that we were approached or kind of, I shouldn't say approached, a conversation began among sort of concerned parties on both sides of a border, our medical staff talking to folks in this community. And then I was sort of approached about the idea of, hey, Dan, would you be interested in potentially looking at a second, opportunity? I would be remiss not to say that a replica of the first one was what was most compelling to me because it's worked so well, and from a family perspective, we were most comfortable with it. So let me just be very clear with you about what that means. There's in New Mexico, there is something called the Arrowhead Research Park, which the Board of Regents designated as a innovation campus where there could be facilitation between private companies or private meaning nonprofit or for-profit with the university, New Mexico State University, to fulfill either certain gaps in the education of that university or to simply facilitate partnerships which could have an impact on the community, the region, the nation, and globally. That was the idea. And we have a lot of cross-border with Mexico and southern New Mexico, so that international designation actually means something. Montana State University has the Innovation Research Campus. It is almost identical to the Arrowhead Research Park. So when we originally drafted the pre-feasibility study, we were interested in looking at, from the perspective of one, having that university relationship, which we think is critical, two, the fact that the WWAMI program is already at Montana State University, so they're delivering substantially all of the curriculum right now that is out in the ether and being delivered at Montana. Three, the campus environment and the university experience for our students, which is important in terms of attracting the top students in the nation and from the region to want to come here. Those were all things that were very important. So what does that affiliation look like down south, and what would it look like up north? Virtually identical. We have a long-term land lease with the university. We have an agreement to buy contract services from them, which things like student housing, student life, access to facilities. They have a reciprocal right on our facilities, things like libraries and subscription to those library services, et cetera, et cetera. And then there's a gift agreement. We make a gift to the university every year of $500,000 over 60 years to New Mexico State. That's a $30 million gift to the foundation. Not a lot of donors that you're going to find to do that. So over a 60-year period, $30 million goes directly into the university, which they're able to use virtually for anything that they want to use it for, scholarships, et cetera, et cetera. And then we have branding, and the branding is important because it allows for the university, through the creation of this independent medical, through the affiliation with this independent medical school, to apply for joint research. So what happens is that in the absence of that, those research dollars kind of just go down, and what we can do is help them really ratchet up. And so that's good for our school, that's good for them. But let me sort of be abundantly clear on one point. These are independent schools. They are independently accredited. John made a point which I think is crucial, which is we will not utilize a single dollar of Montana money, taxpayer money, and we would not want anything from the university where we were not paying for it on a fair market or fair market plus, because I don't want to be in a situation where we build a school, put it into operation, and somehow, whether it's a year or 6 years or 20 years down the road, somebody comes back to me and says that we benefited somehow as a private company from Montana taxpayer dollars to establish the school. We won't do it on that basis. So the only way we'll do it is if we fund it ourselves, if we're accredited ourselves, and the relationship we have with the public universities or the university systems or the state is arm's length and entirely transparent and affiliated. And so that's how we did it in New Mexico. And it really, was, I think, the best way to do it. And I think that's the way we would look to do it here. That's supported by the pre-feasibility study that we just completed. So that, I hope that kind of generally gives you a sense of how we would structure things if we were to move forward with the university. Yep.
Hi, my name's Mary Moe. I'm a state senator from from Great Falls, and first of all, thank you for your interest in doing business in Montana. I previously worked in the commissioner's office and was one of the partners that worked to get the additional whammy slot, so I have that kind of background, which is not to say it's in-depth, but it's at least complex. And I have read your feasibility report and appreciate your posting it. My question has to do with the timing in terms of your feasibility study, and that will not be completed to the spring, but you're asking for letters of support from public officials in the next 2 or 3 months. Can you explain how that works?
So, to my knowledge, we have not asked anybody for a letter of support, certainly not any public official, and we haven't asked the university in any way to put together. We have not, let me put it this way, we've executed no agreements in the state of Montana on this medical school. What we are interested is in understanding, particularly for the hospitals, what they would be willing to do in terms of the creation of new medical programs around the school, and that we are absolutely doing, because we can't finish the finalize the study, and certainly we could not meet the requirements of the national accrediting agency, which is the COCA and the AOA, without demonstrated support from the physician community and from the hospital community. So I think from our standpoint, that's a fact-finding exercise, and what we would look for is the hospitals, after they've gone through the systems, an internal review process, to write us back a letter and say, and this would need to happen by the springtime, look, we as a system are supportive or are not supportive. We are prepared to provide the following in terms of programming, and then we've got to kind of synthesize that into a final document and say, hey, look, to have a sustainable school, we think we need to be at X number of students. We have sort of X number of programs to support that. Is that going to work or not, right? And if the answer is that's not going to work, we're not moving forward. And by the way, even if we wanted to move forward for whatever, I can't imagine why somebody, I can't imagine the motivations of somebody trying to go out and create an unsustainable school. But to the extent that we somehow convinced ourselves we thought it was sustainable, we certainly wouldn't convince a national accrediting agency of that. So I think that's where maybe the letter or the support that we're asking for is coming from. And I wouldn't say we're asking for it. We're asking for the systems to do a true independent internal review through their finance departments and through their medical staffs and through their senior administration, and to come back to us with some kind of conclusion. Thank you very much.
Hi, my name is Jean Branscombe. I'm the CEO of the Montana Medical Association, and this is the first chance we've had a chance to meet. So welcome to Montana, and understand you've been around for a few months, and hopefully we'll get engaged as well. The Montana Medical Association is actually the largest statewide organization of physicians, with 1,200 physicians strong. We've heard from a large number of our membership, and you heard a couple of physicians today being extraordinarily concerned about the capacity in our state for these clinical rotations. And there's been several different meetings in communities that you have been at, Bozeman for one, where those concerns were expressed. So based on the lack of conversations we've had and your plans to have more conversations in the future surrounding that very important conversation to provide quality medical education in the state, my question to you is, how will you earn support of the medical community based on where we're at today to get those clinical rotations supported in our state by those physicians who will need to do those, to provide those clinical rotations for your organization?
Yeah, and I think Robert should answer, because he's going to be the one on the ground, but I think let me answer the first question first, and then have Robert kind of answer the second question. I think on the first one, we've laid out the process, and until we have real data and conclusions, which again is going to take a number of months to finalize. And this has been a very capital-intensive process to go out and do this work, and it will continue to be. It's very hard to come back and ask a physician to support us or oppose us based on the unknown. So the first thing is to finish that and see what the data tells us, and that's what I'm focused on and Robert's focused on. I think once that happens, I think, Robert, you should speak a little bit to what you're doing already around the state with physicians, and then how you would approach kind of delivering the ultimate feasibility study that we will complete, and how we would like to do that. So why don't you speak to that a little bit?
Great. Well, Gene, it's a pleasure to see you again. And I think it was last time we were in a Hilton Garden Inn, also last time we met. And first of all, I'm excited about this process. It's interesting. I've talked to several folks that have been around for a while, and they were saying back about 42 years ago, when University of Washington, based out of Seattle, was trying to bring the WAMBI program to Montana, a lot of similar concerns back then. And I think nowadays, people see, those concerns have been shown actually to be a valuable service for the state. And I think that when we go through the state, meet with physicians throughout the region and the state, I think that we'll have those conversations. What are you willing to do? What does it look like to train medical students in your practice, in your facility? And I can tell you, there have been a lot of physicians. I've been getting emails. I feel like the Rhinestone Cowboy. I'm getting emails and telephone calls from people I don't know that do want to train medical students, and they really want to do so in a very positive way, because part of the professionalism of physicians is not only the patient that's directly in front of them, but it's also a greater good. And to train the next generation of physicians to take care of the future of Montanans and also for the region, I think really, it's part of what we do. And I think that, and I'm looking forward to talking to your members more. And I just got this job a few weeks ago. A little bit more than I thought I was going to get into initially, but I knew it's going to be a lot of work. And I think it's going to be something that Montana is going to be very proud of.
I mean, just a quick follow-up on that. I think as we identify the hospital systems that are willing and excited about partnering with us, and look, this has been a bit of an education process too, but obviously there's a business decision around developing new GME programs, right? And that business decision oftentimes is made at the board level, and it's made at the CEO level and at the administration level. I take at face value that and maybe we need to do more, but you also have to be very careful to not overstep bounds, that when we meet with hospital boards and hospital CEOs, that they are, in making the decision about whether they are interested in building these programs with us, that they're working with their medical staffs to make that decision. Do we want to be a teaching hospital? Do we not want to be a teaching hospital? And it's a little maybe unfair to put us in the position of saying we should somehow get in the middle of that discussion between medical staff and hospital administration and say, somehow we're going to broker that discussion. I mean, that's not a role that I'm going to put myself into. The hospitals have to decide how they want to manage their own teams. And if they say they want to move forward, then my strong recommendation to the hospitals is going to be, okay, great. Once we've have you worked with your teams to develop those programs and what you think your capacity is? Do we have buy-in from the medical staff? And when, Mr. CEO or Mr. Chairman of the board, can I have an opportunity to come in and meet with your team, because they're your employees? So, I just find it a little bit off base when people come to me and say, well, how could you not have come to the physicians first? I don't have the names and numbers of the 2,600 physicians in the state, and I certainly wouldn't have gone behind the hospital CEOs back first to say, let's have town hall meetings about this, and then, hey, you physicians, go negotiate these programs with your medical directors. I mean, that's just not how it's done. So, we've engaged the hospitals, we've worked to engage WWAMI, we're figuring out who the partners are. Once those partners are identified, we want to sit down with the medical staffs and we want to start working with them. And that would be the approach.
Well, this is obviously an emerging issue in the state of Montana. Thank you, Dan. Thank you, Dr. Hasty, for being here. I'm sure that this is not the last of the discussion that we will have.
Appreciate it. Thanks.
Now, we do have a couple of several closing items. The first, again, is the survey. You do have surveys at your table. Please fill out those surveys. If you want to remain anonymous, that's fine. You can either tear off your name and still enter the drawing for $50 gift certificate, or you can sign your name. We will also have an electronic copy of the survey coming out. All of the presentations that you have seen today will be available online in approximately 1 week at MontanaHealthCareFoundation.org. In addition, we'll have a copy of the video, or at least a link to the video, available for you. Bits and pieces, however much you want to watch, or you want to refer other friends and colleagues to. MontanaHealthCareForum.com. What did I say? MontanaHealthCareForum.org. Sorry, Aaron. One more time, I would like to thank our sponsors. You have been tremendous. We appreciate not only the financial support, but also your willingness to attend. Thank you very much. A special thank you to two individuals who got roped into a job today, to Callie and to Julie. Thank you very much for handling the mic and also for handling the timing. It really does help make things a little smoother. And I would be remiss for not thanking Webb, Glenn Opal, who could not be with us today. And one person deserves a special round of applause. That is Stacy Dorrington, for all of the work she did behind the scenes, registration, putting together the packets of information, all of the programs, for gathering the bios, all of that other stuff that is appreciated, but not something that people understand what hard work it is. Thank you to Stacy. Thank you all for attending. We do have our reception out in the lobby, and next year, the last week in November, November 28th, the week of November 28th in Billings. Thank you all for coming.